Your body is not broken, your pelvis is not too small, and your baby surely is not too big. You just need somebody to show you how to navigate the system that tells you otherwise. Surprise, it's me. Hello and welcome back to another episode of the Birth Lounge podcast. You guys, have you heard about my brand new course, Birthing Your Big Ass Baby? Well, it was highly influenced by all of you because every single day, no lie, I get so many messages either on email, text messages from friends in my life, or DMs on TikTok or Instagram where people are leaving their prenatal appointments and they're being told a bunch of bogus stuff like, well, your baby is measuring a little bit big, so we're not sure if you're going to be able to do this without an epidural. Or, well, we might need to schedule a 39-week induction based on the size of your baby. But here's the truth, and here's what most people don't know. There are actually less than 1% of all U.S. babies that are born to meet the criteria of macrosomic, which is 4,500 to 5,000 grams. And here's the other thing that ACOG says, but they don't exactly shout it from the rooftops, so I will. The methods in which we use to predict or estimate these baby size are highly off by like 15 to 20%, which translates to 1 to 2 pounds either way, which means that if you are having a reading done and it says that your baby is measuring 8.5 pounds, then really you might have a 6.5 to 7 pound baby all the way up to a 10 to 10.5 pound baby. So when we're making these decisions off of these really inaccurate methods, that means that we're actually intervening in a lot of cases unnecessarily, which obviously is responsible for thousands of unnecessary inductions and C-sections every year. And almost none of them are wanted and nearly none of them are evidence-based. Now, one other thing that gets thrown around when it comes to a quote-unquote big baby is shoulder dystocia, which obviously is really real and very scary, but also super rare. We're going to talk about it later in this episode, but I did want to share another little quick stat with you, which is that in order to prevent one shoulder dystocia, we would have to perform 3,000 C-sections. 3,000. That is 3,000 C-sections to prevent one shoulder dystocia. Now, again, just stick around because I'm going to dive into this later in this episode, but I really wanted to lay it out so clear for you that a big baby is not a reason to be induced or have a preemptive C-section unless you want to. And in that case, go for it. I've got so many resources to share with you. How can you actually have a positive induction? Our team supports so many inductions every single year because people want them, and we are able to help them achieve not only really nice and grounded, calm inductions, but vaginal inductions that you don't have to push for hours and hours, and inductions that don't leave you traumatized. You deserve to understand what's fact and what's fear, and that's exactly why I created Birthing Your Big Ass Baby course. I promise you this is not another fluffy birth class, and this is not some class that's going to teach you just to say no. I'm really giving you all the data, and under every single video, not only do I spell out the data for you, but I link it for you too. So this does two things. It puts it right in your hand, but you can also print it out and take it to your provider so that when you're you're having these discussions, not only do you have it with you, but you can share with them how you've come to your conclusions. This course is truly a deep dive into what the research actually says about big babies, labor positions, how to protect your birth plan from being derailed by outdated protocols, and how can you avoid falling victim to fear-based tactics when there's absolutely no facts in the argument. So what you're going to learn in Birthing Your Big Ass Baby includes what macrosomia really is and how often it's actually misdiagnosed, why ultrasound estimates can't be trusted for decision making, and how they lead to actually increased numbers of unnecessary inductions and C-sections, how upright movement and gravity can make more space for your baby. Yes, even the really quote-unquote big ones. The truth about shoulder dystocia and why it's almost always resolved safely without a C-section, and the fact that induction can neither prevent it nor predict it. Also, we're going to dive into what ACOG really recommends about induction and C-section. And I'm going to give you advocacy phrases to use when you're feeling pressured, including how to say no without confrontation. I want you to be able to walk into your birth with evidence-based decisions and feeling confident, clear, and calm about those choices. Your body is not broken, your pelvis is not too small, and your baby surely is not too big. You just need somebody to show you how to navigate the system that tells you otherwise. Surprise, it's me. I've spent over a decade supporting families through births that were labeled high risk or too big or too long or too complicated. And I can tell you the difference between panic and peace isn't luck. It's literally the way that you prepare. If you've ever wondered what to say when your provider recommends an induction just in case or tells you that your baby might be big, then you need the Birthing Your Big Ass Baby course. Right now, we are still in the pre-sale phase, so that means the course is launched, but you get to still take advantage of a pre-sale price until November 1st. You can visit thebirthlounge.com/bigbaby and grab the course for just $99. Again, that is thebirthlounge.com/bigbaby and jump on that sale price before the investment increase on November 1. Once you join this course, you'll be able to see straight through the fear and know exactly what's evidence-based, what's not, and how to stand in your power, no matter who's in your room, no matter who shows up on call, and no matter what they present to you in labor. This is your birth, your baby, your decision, and I'm going to show you how to protect that power. I'll see you in Birthing Your Big Ass Baby. All right, let's dive into the top 6 things that you need to know when it comes to a quote-unquote big baby. Now, number 1, I think it's really important for you to understand what macrosomia really is. So macrosomia, defined by ACOG, is a baby that weighs more than 9 pounds, 15 ounces, all the way up to a baby that is 11 pounds. Now, those babies, they make up less than 1% of all U.S. babies. So 99% of women are having average size babies, which falls below that 9 pound, 15 ounce mark. So when you have a provider who is sharing with you that your baby might be big, that could be true, but there are a couple things you want to ask. Number 1, what's the likelihood that I'm in that 1%? Number 2, how are we diagnosing, quote unquote diagnosing, or how are we estimating the weight of this baby? Because the truth is, we literally don't even have an accurate way to estimate your baby's weight. Ultrasound is off. Belly palpations, where your provider literally just feels around on your belly and they palpate it. They kind of squeeze your belly and push around, and they estimate with their hands and their clinical experience how big your baby is off. And then we all know that the age-old methodology of pelvimetry is not only not evidence-based, but it's just plumb off. You can't estimate the size of a woman's pelvis by looking at her. And you can't send her through an x-ray and then determine whether her baby is or is not going to fit through her pelvis during labor. Number one, our pelvis expands 30% in labor. And number two, your baby and your pelvis do this really beautiful, magical, dynamic dance in labor that we can't predict how that's going to go. And so when we think about how we're gathering these estimations and in which way we're trying to predict whether this baby is going to be big or not, we don't actually have an accurate way of doing that. So if that is true, then that lends me to the question of why would we be making decisions preemptively while you're still pregnant based on methodologies that are not accurate, not even a single one? It actually makes no sense. So now that we've described macrosomia and you know what it is, now it's really important for you to understand just how often it is overdiagnosed. Many of these quote unquote diagnoses of a big baby are actually just a guess. And oftentimes it's used as a way to justify induction or even scheduling a C-section, even though the data shows and ACOG says that they're actually really terrible at predicting the size of a baby. We also know that there's no improvement with growth curves, longitudinal scans, or 3D ultrasounds. Now, one thing to know is if you have had a big baby before, so a baby that's over 9 pounds 15 ounces, then your odds do increase about 5 to 10 times to someone who hasn't had a big baby before in having another big baby. However, again, regardless of your birth history or not, we can't diagnose it until after birth because every single thing is an estimate. So remember, the phrase, "oh, your baby might be big," is not a medical diagnosis. Rather, it's an invitation to ask better questions. Number one, I would ask, how big do you estimate my baby is, and what's the margin of error in the method that we've used? And then second, I would ask for the ACOG bulletin or the data that they're basing that decision on. Now, you don't have to go look that up if you're in the Birthing Your Big Ass Babies course. I've linked it for you. That way you can have it. You can screenshot it on your phone. You can print it out. But you do want to make sure that your provider is referencing actual data points when they're making clinical recommendations to you. So that would be my first starting point. All right, number two is understanding shoulder dystocia because obviously that's super real, it's super scary, but it's also super rare. Now, ACOG estimates that it happens in less than 3% of all births. So again, you've got a 97% chance that you don't have a baby that experiences shoulder dystocia. Now, we do know that there are some things that influence the likelihood of shoulder dystocia happening or not happening. Number one, your birth position. So if you're on your back, you're increasing the chance of shoulder dystocia because we are immobilizing your pelvis. We are closing off the space in which your baby has to navigate the pelvis, and we're making it more likely for that shoulder to get a little stuck. So instead, get up, labor upright, birth upright. We also know that gravity plays a huge role. So if you're laying on your back, think about how gravity is impacting not only the path that your baby has to take to get out, but in which way is gravity pulling your baby? Well, it's pulling them towards your spine, towards your tailbone, down towards the ground, but your vaginal opening is actually perpendicular to that. So we're really not using gravity in a smart way. It's working against us, not with us. And then finally, your pushing technique all influences this as well. And so that's something I teach you in the secret sauce to pushing, which is another course you can grab. Or if you're in the birth lounge, then you just have access to all of these courses automatically. Have you heard about the baby soap debacle that happens in the L&D rooms across the US? Well, if you haven't, then let me let you in on a secret. The hospital system often will use something like Johnson & Johnson's baby soap as a lubricant in labor. So remember when we were all little girls and we were told not to put soap in our vaginas because it can throw off the pH? And even now as adult women, we're told that we don't need to wash our downstairs lady because she is self-cleaning. She can do it herself. But then in labor, they're going to put Johnson & Johnson's of all soaps in your vagina to what? Help your baby be more slippery, which they don't even need. But I understand if you might want a little extra lubrication down there during the pushing period, and I have a much better option for you. Coconut. And if you haven't heard of Coconut, it is one of my favorite lubes. Coconut's products are made with all organic coconut oil, organic coconut water, and other natural ingredients like organic beeswax, organic cocoa butter, organic sunflower oil, and organic shea butter. Because you know what? What you put in and on your body, specifically for your vagina, the details matter. I love that Coconut uses plant-based, non-GMO ingredients, which are also USDA certified organic whenever possible, and their packaging is plastic-free, and it's made in the US. Coconut offers oil-based and water-based because if you use toys in the bedroom, you shouldn't be using oil-based lubes with those, only water-based. So they wanted to give you both options, but I gotta be honest, my very favorite product that they offer are the singles. These are single packets that you can literally order a box of, put them in your birth bag, and then if you need extra lubrication during labor, you take the box out, use the single packets. You can use one, you can use all of them that come in the box, and I just love it. I think it is such a better option for you to not only give you that extra lubrication if you want it, but you don't actually need it during labor. It helps you have healthier, better sex during pregnancy because obviously we want to make sure that everything you put in and on your body in pregnancy is organic and safe for you and your baby. And it's much better than Johnson & Johnson baby soap, which is going to disrupt the pH of your vagina. Which, who wants a yeast infection in postpartum? Yuck, not me. What an actual nightmare that would be. So head to coconu.com, that's COCONU.com, and use code HeHe to save 15%. Coconu.com, use code HeHe, HeHe, to save 15% and protect the pH of your downstairs kitty. Meow. When it comes to pushing out your baby, especially one that is suspected to be on the larger side, we really want to see you engage in what's called open-glottis pushing, which really means that your knees are in. Now, this could feel very foreign to your medical staff. A lot of times they are used to and trained to have your knees wide open and to have you on your back. But open glottis pushing means that we're actually opening the outlet of your pelvis, which is that bottom part of kind of where your sits bones are, which is going to help accommodate your baby's exit through your body by making the exit of your pelvic bones wider. When your knees are wide, the outlet of your pelvis is small. When the opening in your knees is small, then the opening in your pelvic outlet is big. It's opposite. They work together, right? And so we want to close those knees so that we can actually have a nice wide outlet, especially for a baby who is quote unquote big or expected to be big. Although we know that obviously big babies are pretty rare and that most likely you do have an average sized baby coming through there. The other thing that I find absolutely fascinating, and again, this is all linked for you in the Birthing Your Big Ass Babies course so that you can see it straight out of the horse's mouth. ACOG says that most cases of shoulder dystocia actually happen in babies of average size weight. So this ideation that shoulder dystocia is so much more dangerous with a big baby, or that a big baby almost guarantees shoulder dystocia, is literally just false. It's just this completely inflated narrative. I don't know where it came from, but it certainly is used to scare women. And I think it's really important for you to know that. So if you have a provider that is saying, well, this baby is big and I don't want you to have shoulder dystocia, so we should induce or we should have a C-section, do know that none of that is evidence-based. Not the fact that a big baby could cause shoulder dystocia, not the fact that an induction could prevent it, and not the fact that a C-section is better. Absolutely none of those are backed up with the data per ACOG. And then finally, the other thing to know about shoulder dystocia is it is incredibly manageable. All providers, healthcare providers, are trained in how to resolve shoulder dystocia. There are a number of maneuvers, and I actually go into them in depth in the Birthing Your Big Ass Baby course, and I show you what they all look like. So not only do you know how to have conversations about these, but you also will know what to expect should you experience a shoulder dystocia. So just remember that the incidence rate of shoulder dystocia is actually quite low. They're almost always very manageable, especially if you have a team that can remain calm because of their training rather than panicking. And then finally, episiotomy, induction, and C-section doesn't avoid shoulder dystocia. Which leads me to my next point, which are the ways that the hospital system can sometimes present to you to prevent or predict shoulder dystocia. Now, we've got 3 different things that they will often suggest to you. Number 1, an induction at 38 or 39 weeks. Number 2, a scheduled C-section. And number 3, you might have a provider that talks to you about episiotomy. Super important to understand that none of these things are actually evidence-based. ACOG actually says that episiotomy does not give any more benefit, and it actually has been shown to cause more harm. Interestingly enough, people who did not have a routine episiotomy had fewer severe tears. They reported less pain in postpartum, and they were less likely to experience incontinence or sexual dysfunction later on. So in other words, routinely cutting your perineum doesn't actually improve things, but it does make recovery, especially long-term recovery, way worse. Now, I do want to note that there are some really rare and specific situations where episiotomy might be helpful, and ACOG does recognize this. I actually lay them all out in the Birthing Your Big Ass Babies course, so you can head to thebirthlounge.com/bigbaby if you want to hear about those. And of course, as always, the data is linked so that you can dive into that to see if it is actually applicable to you and how likely you are to maybe need an episiotomy as an individual, but not with blanket statement healthcare. The other thing that you should know is that when you're having a conversation with your provider and they say something like, well, we should just induce you or schedule a C-section because your baby might be big. Well, the research doesn't actually support routine induction or C-section for a suspected big baby. Actually, these 2 things are quite a myth. Now, in ACOG Practice Bulletin 216, which is behind a paywall, but I've paid for it and I've downloaded it and I've given you access to it in the Birthing Your Big Ass Babies course. That way you have it. You can print it out. You can screenshot it on your phone. You can take it in to talk to your provider about it. They actually literally say in black and white words, suspected fetal macrosomia alone is not an indication for induction of labor. So why not? Well, because induction doesn't actually reliably reduce shoulder dystocia, but what it does do is increase the chance of a C-section for you. So you're kind of taking this hypothetical, we kind of think it may, even though the data doesn't show it does benefit, and you're trading it for a very real, data-backed, totally proven risk of increasing your chances of having a C-section. Now, obviously, there are some good medically indicated reasons to have an induction. I'm not saying induction is never needed. What I am saying, and ACOG says the same thing, is that if your only indication is that your baby is big, then that would be an elective induction. That's not a medically necessary reason. And again, not my opinion. ACOG straight up says it in Bulletin 216. One other thing they say about macrosomia in Bulletin 216 is prophylactic C-section is not recommended for suspected fetal macrosomia with estimated fetal weight of less than 5,000 grams. So remember, that's an 11-pound baby. I mean, that's a huge baby. That's basically a kindergartner walking out of you. In women without diabetes, or less than 4,500 grams, which is that 9 pounds 15 ounces, in women with diabetes. So ACOG stands very strongly against C-section solely for the reason of a quote-unquote estimated big baby. Well, why is this? Probably because C-section is a major abdominal surgery and they recognize that it carries higher risk of other complications like hemorrhage, infection, longer recovery, and also complications with future pregnancy like uterine rupture and placenta accreta. A C-section is not without risk, which neither is a vaginal birth, but C-section certainly comes with much higher risk than a vaginal birth does. So I know I've said it before, and I'm just wanting to clear it up one last time so that you really, really take it to heart. But a C-section and an induction neither predicts nor prevents shoulder dystocia, and they are not evidence-based ways to handle macrosomic babies. So just remember, whether your baby is big or not, your body was designed for this, and evidence-based physiological birth is still the safest path for most families because we know that 99% of families are going to have an average size baby, and 97% of women are going to have a birth that doesn't involve complications like shoulder dystocia. So what does matter? How are you going to get this big baby, quote unquote big baby, out of you? Well, number one, position matters way more than size. And I'm talking about your position as well as your baby's position. So I mentioned earlier that upright labor is super important. And I would say that if you're looking at a, diagnosis or an expected big baby, then it's even more important for you. We want you to be laboring upright. So stay off your back. And this isn't just for people who choose unmedicated birth. In the Birthing Your Big Ass Babies course, I actually take you through a ton of birth positions for unmedicated and epidural birth. I want to actually show you how do you engage in upright labor no matter what your labor goals are. Because you know me, I don't care how you birth. I just want you to know what your options are so that you can choose what's best for you. And remember, if you have hospital staff that's discouraging you from being upright in labor, you should probably ask for a new nurse or a new doctor. We know that upright labor not only helps facilitate an easier and faster birth, it helps your uterus contract better, but if you're looking at a suspected macrosomic baby, this is the key to helping you avoid further interventions and an unnecessary C-section. So as far as your baby's position goes, that upright labor is going to be what achieves that. Don't forget too that late in pregnancy, you can be doing other things to help encourage your baby to get in what we call optimal fetal positioning. So spend time on your birth ball. Prioritize things like walking upstairs, curb walking, things that really get your hips uneven, cat-cows, windshield wipers. If you visit my Instagram, Tranquility by HeHe, I actually show you a ton of exercises that you can do to help get your baby in optimal fetal positioning for labor. And then finally, we really want to push upright as well. Like I talked to you in the opening of the episode, when we have your tailbone immobilized by being on the bed, it really does hinder your baby's ability to navigate your pelvis. So again, regardless of whether you are medicated or unmedicated, in the Birthing Your Big Ass Baby course, I actually show you different upright birthing positions that you can use with or without an epidural that are going to help facilitate your baby's navigation of your pelvis. These are the things that you really want to know going into the hospital system, because it's kind of hit or miss, and it really is based on who's on call, what nurse you get, and what the facility unit's culture is like of where you're birthing. That will determine how open your staff is and also how knowledgeable they are of these things. So your best bet is to have the knowledge yourself so that you can go in there and say, actually, I appreciate you suggesting that I side lie. I would like to drop the foot of the bed, raise the back of the bed, and get into a throne position. Now, your nurse may not know what that is, and that's a-okay, but you and your partner will know what that is, and you'll be able to help your nurse facilitate getting your body into upright positions. And my last point in true HeHe fashion is helping you understand true informed consent, autonomy, and your freedom of choice in this experience. It's super important that you are the one that is making decisions throughout this journey. The way that we prevent birth trauma is really keeping you in that driver's seat, because we know that so much birth trauma is actually avoidable by very simplistic ways, actually. It's just really making sure that you're the one who's calling the shots. Are you the one that is making the choices about your body? Are you the one that has the final say? Making sure that no one in your room is telling you what you can and can't do, that you're not being dismissed, that your healthcare team isn't talking around you and about you, but rather with you and to you. Being included in your healthcare decisions is really one of the easiest ways that we can help prevent birth trauma. So I wanted to teach you a couple of advocacy phrases. I've got 3 here that I want you to walk away with this episode. And then in the Birthing Your Big Ass Babies course, I actually give you questions and phrases in every single module. So there are 10 modules. So you're walking away with a ton of questions for every single situation. Number 1 is, I'd like to understand all of my options before making a decision. Number 2 is, I hear your recommendation, but I don't consent to that at this time. And number 3 is, I would like to try, insert an alternative that you want to try, before we do X, Y, and Z. Now, I know that you've probably heard this before, but your provider's philosophy and their belief in you of whether or not you can actually birth your baby matters way more than almost anything else. Not only is their energy going to carry into your room, but the language that they use as well. Plus, the options and the discussions that they have with you are going to reflect these beliefs and these preferences and these philosophies too. So one of the most important things that you can do when it comes to setting yourself up to have a positive, trauma-free vaginal delivery, especially if your baby is suspected to be big, but actually regardless of the size of your baby at all, is to find a provider who is aligned with you. And when I say aligned with you, I mean that when you walk into their office or their clinical space, you don't feel like you need to lie to them. You don't feel like you need to shrink. You don't feel like you're headed into a fight. You don't feel like you're always having to defend yourself. Instead, you feel collaborative. You feel like you can tell them anything. You feel like you trust them. And when you leave, you feel warm and fuzzy. You feel supported. You feel heard. You feel like the things that you shared with them, They really understood and they met you where you were, and they genuinely care about helping you have a good birth. Now, obviously, I would be remiss if I didn't mention healthcare deserts in our country, and it's super unfortunate that we've got whole counties that don't have a single OBGYN, and it's very tragic that sometimes you have to drive 2 or 3 hours to get to an OBGYN. But here's what I will kind of gently and lovingly nudge you to consider. If you're already driving 2 to 3 hours to the east to see an OBGYN and you don't like this person and they don't make you feel supported, and every time you go, you're like, just filled with dread, what's the harm in driving 2 to 3 hours to the west or the north or the south to a different town to find a better OBGYN? And listen, I get it. It's a pain in the ass. I understand. I totally understand the mental load of being pregnant and having to make all these decisions and trying to think through all these things, which is why I put together the birth lounge. I wanted to take that mental load off of you, and that is what I do in the birth lounge. I take it off of you because I've already thought through all of these things, and your only obligation, your only responsibility is to sit down, consume the information. I've given it to you on a silver platter, and now you just need to make sure that you're making the decisions that feel good to you. I also have linked the data. We have resource lists. I've thought about the questions you need to ask. I've thought about all the things that you need to consider. So all that extra mental load, I already did it for you inside the birth lounge. Nevertheless, it's still a lot. However, I really do understand how much of a daunting task it can feel like to change providers. But what I will say is, when you find a provider that supports you in a way that you deserve, that makes you feel heard and seen, you will realize just how good it can be. You deserve a birth that is joyous and grounded and calm and supported. One that uplifts you, one that leaves you entering motherhood feeling so supported and loved and empowered, and knowing that you are so informed and you have the confidence and the skills to mother this baby, to do the right thing, to make the decisions that are best for your family without relying on outside sources. Everything you have is already right inside of you. You just need somebody to remind you of that. So remember, you can do this. Your body is capable of birthing your baby, regardless of their size. Your pelvis isn't too small. Your baby isn't too big. And big babies are not to be feared. A system that tries to convince you otherwise is. All right, you guys. I would love to see you in the Birthing Your Big Ass Babies course. It truly is changing the game for so many women. We're reducing the induction rate, we're avoiding unnecessary C-sections, and we are helping women all over the world achieve their ideal birth by avoiding things that don't feel aligned to them and are completely unnecessary and not founded in any sort of evidence. And I want that for you as well. You can head to thebirthlounge.com/bigbaby to join me in the Birthing Your Big Ass Babies course. Again, that's thebirthlounge.com/bigbaby, and I will see you in the next episode. Be sure to follow along with me on social media. You can find me at Tranquility by HeHe and at the.birth.lounge. Until next time, head to your app store and download the Birth Lounge app for evidence-based childbirth education and data-driven postpartum support delivered straight to your phone. Bye! Thank you so much for tuning in today. I love hanging out with you, and it is an honor to be your go-to gal when it comes to preparing for your baby. If you've enjoyed today's episode, please leave a 5-star review and tell others why they should be listening to the Birth Lounge podcast too. You deserve to have a birth that you love with a provider that values your autonomy and respects informed consent without all the trauma that you so commonly hear about on social media. New episodes air every Wednesday and Friday. Hit that follow button so you never miss an episode. I'm HeHe, and this is the Birth Lounge Podcast.